What physical therapists need to know about MCL injuries? What's going on, guys? This is Dan Pope and Kevin Coughlin. We are physical therapists from Champion PT and Performance. We're here going over the medical literature on topics, diving deep, pulling out all the good information for you, adding in our clinical expertise, and hopefully helping you learn a little bit. What's going on, Kevin?
Not much, Dan. Not to date the episode, but how was CSM?
CSM was wonderful. Learned a lot. Had a great time hanging with some friends, and it was delightful. I'll say that.
Awesome.
Yeah, let's get cracking into this. All right, so first we'll summarize a little bit about what we're going on over today. We're going to go over the prevalence and incidence of these injuries, common populations, the mechanism of injury, anatomy and pathophysiology, clinical examination, differential diagnosis, and treatments. Should we be treating these conservatively? Should we be prescribing some surgery? Should we be doing conservative treatment first? Who the heck knows? What do you think, Kevin? Just seemed like a fun one?
I like the layout. Seems pretty good.
Okay. And then I'm taking a lot of information from this paper. This is from the British Medical Journal, Open Sport and Exercise Medicine Journal, shedding light on the non-operative treatment of the forgotten side of the knee, rehabilitation of medial collateral ligaments, a systematic review. And when I first saw this, I was like, well, I feel like the LCL is much more forgotten than the MCL, but maybe the MCL is more forgotten and the ACL is the common one, which is probably what they're hinting at, I think, for this study. All right, let's get into it. Prevalence and incidence. So MCL injuries are the most common ligament injury of the knee, right? So that was my first thought. The forgotten side of the knee, this is the most common injury that you're going to see, right? But it's important to keep that in mind. I think what happens is that the ACL takes the spotlight, probably because it's a much bigger problem and the rehabilitation is much harder, right? But you're probably going to see much more MCL injury than you are ACL injury. So how common are these? In elite football players, soccer players, right? This is from an international journal, so it's going to be football everywhere else. There's an average of 2 MCL injuries per season per team. If you compare that to the ACL, it's 0.5 injuries per season per team. I believe that's in males. Makes up 7.9% of all athletic knee injuries. The annual incidence is somewhere around 0.24 to 7.3 per every 1,000 people. The reason why there's such a big difference there, 0.24 versus 7.3, is probably just due to the sporting folks are going to have much higher likelihood of MCL injury. If you play 0 sports whatsoever, it's going to be a lot less common, right? The male to female ratio is 2 to 1. So you're seeing more MCL injuries in males versus females, which is kind of interesting because if you compare ACLs, it's kind of flipped, right? More ACL injuries in females, more MCL injuries in males. And common sports where you'll see this injury, it's going to be in soccer, skiing, as well as ice hockey. Any thoughts there before we move on, Kevin?
Yeah, I think what you said was pretty interesting. I wasn't aware of those numbers. So I think, first of all, I wouldn't have thought it was the most common ligamentous injury. It's pretty interesting. Yeah, and secondly, you wonder why more males than females. Also interesting, but cool to learn.
Yeah, I don't know either, but at least it's something that on your radar when you see someone has medial knee pain. The most common ligamentous injury is going to be the MCL. So you might be dealing with that, right? So I hope you're ready for your head to blow up in a good way, of course, because I have something that you're going to love. It's an evidence-based cheat sheet for MCL injuries. Staying up to date on the literature is a pain in the butt, and my butt hurts. But yours doesn't have to, because I've done the work and going out there and reviewing the literature. I've taken all the good stuff and none of the fluffy stuff and condensed it into a nice little cheat sheet. My promise to you is I'm going to catch you up to date on the latest literature on these ligament injuries in under 10 minutes. These babies are action-packed, but not too packed. We go over prevalence and incidence, common populations with this injury, anatomy, mechanism of injury, clinical examination, differential diagnosis, and all the different treatments, conservative and surgical. Best of all, this bad boy is free. So I'm going to leave a link in the description. Go ahead and click on that and download it. My promise, I want to catch you up to date in under 10 minutes. I hope you enjoy. Now, back to the learning. Okay, let's go into the mechanism of injury. So it's generally injured traumatically. And usually if it's a contact injury, it's to the lateral it's to the lateral side of the knee, creating a valgus force, typically around 20 degrees of valgus. If it's going to be above that, the injury might be a little bit different. If it's below that, it may not cause an injury. And usually there's tibial external rotation of the knee, which little bit of a spoiler alert, but this causes a lot of different types of injuries, right? So that's kind of the same way you could injure your ACL. It's actually how you could also injure the posterior lateral corner. So this mechanism causes a lot of problems. Obviously, it can also occur from a non-contact perspective. We often see these associated with ACL injuries. So if you plant your foot, pivot, then you have dynamic valgus and rotation at the knee, that can also create an MCL injury. And like I said, it's often injured together with the ACL. Some background on MCL injuries. We can grade them, obviously. It's not like when you have an MCL injury, it means it's always torn. Grade 1, when you test the knee, there's no valgus laxity, or there's going to be 3 to 5 millimeters of medial joint opening, which may more or less be normal compared to the other side. Grade 2, valgus laxity at 30 degrees of flexion. And I think for all of these, so for grade 1, they were looking at 30 degrees of flexion as well, but also in full extension. Grade 2, you're going to see 6 to 10 millimeters of medial joint opening. And then grade 3, you've got valgus laxity at 30 as well as 0 degrees of flexion. So I apologize. I think I may have confused you, but grade 1, you're not going to find any valgus laxity with the knee straight or the knee bent slightly. Grade 2, you're only having valgus laxity at 30 degrees. Then when you go to straight, there's no valgus laxity. And grade 3 is going to be valgus laxity at 30 and 60 degrees of flexion with greater than 10 millimeters of medial joint opening. And generally what this means, if you have knee laxity at 0 degrees of flexion, then you generally have concomitant injury to the posterior oblique ligament. And that's going to be important because once the posterior oblique ligament becomes involved, then it changes the thought process of whether or not we need to have surgery or not. But a little bit more on that later. Any thoughts there before we move on, Kevin?
Yeah, I do always remember at work, kind of Mike and Lenny saying that if you have someone with MCL pain and they're getting a reproduction of pain at 0 degrees or so in full extension, with that stress to the MCL, that it's probably a little worse prognosis. It's probably worse damage to the knee. So that's interesting to see why. Is that posterior oblique ligament? Is that a separate knee ligament?
Yeah, just a little bit further posterior. So we'll
Nice.
look at a little bit of anatomy in a minute, but yeah, it's just a little bit behind the MCL there.
Gotcha. So with those grade 3s, that's commonly involved as well.
Yeah, and we'll go over in a second, but the MCL gets a little bit more taut as you flex slightly, and the posterior oblique ligament gets a little bit more taut as you get to 0 degrees. So when you do the stress testing, you're kind of testing one or the other depending on how much knee
Mm.
flexion you have.
So, okay. So it's 0 is a little more that one.
You got it. Yep.
Gotcha.
Okie dokie. Let's get into the anatomy a little bit. So you have two parts of the MCL. You have the the superficial MCL and the deep MCL. We'll just call it the S MCL or the D MCL. The superficial one is one of the most important medial knee stabilizers. It attaches from the distal femur to the proximal tibia. You can see the attachment points if you're watching this on YouTube. And the superficial MCL has two attachments on the tibia, proximal and distal. It's actually pretty surprising how far down the superficial MCL can attach. This becomes relevant eventually when we talk about different types of MCL tears, just because you're getting pretty close to that pes anserine attachment, right? So just take note of that now, just because there's a specific type of lesion where you might end up needing surgery, just because you can have a tear and then it doesn't heal back down because it gets caught up in that pes anserine. The other piece about the MCL, it's really nice. It's an extra articular ligament, which means it has a good healing ability. What I've been finding, and we'll talk about this more in the LCL talk, we're not really sure how well these ligaments heal, right? We've traditionally thought that if you had an intra-articular ligament like the ACL or PCL, those don't heal well. And now we're kind of finding that maybe they do heal a little bit better than we once thought, depending on whether or not you're using something like a cross bracing procedure. And I've heard the same thing for the LCL. The LCL is extra articular, but I've also heard it doesn't have good blood supply. But spoiler alert, that thing heals too, or it does regain some of its capacity and folks get back to activity. So more research is probably needed, but I think it's interesting that we're starting to figure out that maybe things heal better than we once thought. Any thoughts there before moving on, Kevin?
Yeah, I think it's just a good refresher that the anatomy is always a little more complicated than you think, and it's worth looking back and refreshing with this stuff. So I think that was awesome.
Yeah, cool. The other thing is I really like that we're doing these kind of literature reviews because, you start to realize that some of these kind of older notions that you were taught in school are not really substantiated by much,
Hmm.
right? And we're
Hmm.
just kind of going based off of poor data. And then when you start to dig in this deeper, you're like, well, some of the stuff might not be supported, but we'll delve into some of that when we get into the LCL, but just interesting. Okay. Going into the anatomy of the deep MCL, there are two arms, the meniscofemoral and the meniscotibial. So basically, this attaches to the medial meniscus to the joint capsule. So if you have someone that had a meniscus repair, sometimes they're going to be a little bit cautious, let's say knee flexion, just because the hamstring as well as the MCL, everything kind of attaches together in that area. So you have to be a little cautious with those patients. The posterior medial corner is something that I really wasn't too aware of, but consists of the posterior oblique ligament, the semimembranosus insertion, the oblique popliteal ligament, the medial joint capsule, and the posterior horn of the medial meniscus. So I did know more about the posterior lateral corner, but you also have a posterior medial corner. And just like when you have a posterior lateral corner injury, that can create some instability. Same thing goes with the posterior medial corner. And you have damage to these structures, that leads to anteromedial rotary instability. And that's a problem because this tends to need more surgical intervention compared to just having an MCL injury in isolation, right? So it's important we're just on the lookout. So like when you had said previously, when you do valgus stress testing at 0, that is a sign there's more damage, but also maybe a sign that this person needs some more surgical management as well. So if you're seeing a lot of laxity when the knee is straight, I'm automatically thinking we better send you back to the surgeon, right? Because if you do have an MCL injury, I think the traditional thought is like, oh yeah, that thing heals really well, don't worry about it. But if you damage a bunch of additional structures, that may be problematic, right? So make sure that's on your rehab radar. Any thoughts there, Kevin?
Yeah. So would you kind of use that as a recommendation for now? If you're seeing clinically laxity and pain at 0 degrees of knee flexion, that it might be worth at least referring for imaging initially and see what's going on before trying to rehab conservatively?
I think so, right? And the doc may end up sending the patient right back and say, just do conservative rehab, but there's
Hmm.
something funky going on there. I think we just have to be aware of that. So,
Good to know. Yeah. Awesome.
all right, a little bit of anatomy. I apologize for folks that are listening to this. At some point, maybe you need to go on YouTube and check this out. If you're driving, pull over immediately. I'm just kidding. But anyway, we have an an image of the inside of a knee. There's a couple of things that I wanted to point out here. So on the left image, you have the superficial MCL, and it's big, right? You can see just how big that thing is. And when you tear it, you can tear it on either end or right in the middle. So it's not like the MCL sits right in the joint line. It basically kind of goes down and up right above that joint line as well. A couple other things I wanted to note, and you can't see it too well, but the gracilis and the semitendinosus, so basically the pes and serine muscles, have been deflected, but they go right over the MCL, right? So they're pretty much lying right there. You can also see that semimembranosus. They're pulling that back with a fake, I don't even know what that is, like metal prong, right? And then right below that, and it's not labeled, but that's a medial gastroc. And we're going to talk about dynamic stabilizers in a bit, but those all go right over the medial joint line. So you have a patient with an MCL injury, I think those muscles become extremely important. So you make sure that just targeting them a little bit. On the right image, you can see the deep MCL right there. It's the superficial MCL has been cut. And I don't think there's anything that was super important to point out there, but you can just see that the deep lies below the superficial. Let's talk a little bit about biomechanics. So the MCL is a static stabilizer, meaning that it's not attached to a muscle. It doesn't contract, right? Generally speaking, it's going to resist valgus forces on the knee. At 25 degrees of knee flexion, the MCL provides 78% of the valgus restraining force. So essentially, we're talking about before, if you bend the knee a little bit and then apply a valgus force, you really are testing the MCL. The MCL also resists tibial rotation along with the posterior oblique ligament and the posterior medial corner. So we'll talk about some special tests in a minute that also apply a little bit of rotation to the joint. And we are testing that posterior oblique ligament there. The superficial MCL, or the anterior fibers, are most taut in knee flexion, like I said. the posterior oblique ligament is most taut in knee extension. So in extension, the ACL and the posterior medial corner, the POL, the medial meniscus, and the semimembranosus also contribute to valgus stress of the MCL. It provides 57% of the restraining force against valgus stress. And the superficial MCL posterior fibers are going to be most taut in extension. Basically, in general, an isolated MCL tear leads to valgus laxity and inflection, while additional injury to the secondary valgus restraints, the PMC or ACL, leads to increased laxity in extension. So to your earlier point, if you straighten out the leg and apply a valgus force, yeah, you're checking the MCL a little bit, but you're also checking the posterior oblique ligament, and you're also checking the ACL too. So if you have a lot of laxity there, we tend not to think about it, but that's potentially a special test for the ACL. Does that answer your earlier question, Kevin?
Yeah, definitely. And I think that's a really good clinical pearl. And it makes sense why it's a little more serious to have a positive special test with that type of clinical symptom. So, yeah, it makes me think I have a patient right now who had a ACL reconstruction about a year ago, and they actually did a MCL repair, which I thought was interesting because, like we said, it's a very broad sweep statement to say that MCLs heal well on their own. And why did this doctor do surgery? But I think it's more complicated than that. And it gives me a little better insight as to what he might have been seeing to do this surgery. And actually, her MCL repair had failed and she's scheduled to get another surgery. So she definitely has laxity and pain at 0 degrees of knee extension. So in this case, it is correlating with more significant symptoms to where the surgeon thinks it's wise to repair it again. It makes me think what other structures there are implicated. And I think some of the ones you had talked about probably are. So I think that's awesome good clinical stuff.
It is a little bit of spoiler alert, but there are specific lesions. Sometimes when the MCL tears, it doesn't tear and then lay down where it's supposed to. Sometimes the fibers end up kind of sticking out or they get stuck within the pes anserine. It's called a Stenner lesion. And then, yeah, that's not going to heal down well because it's just not attached, right? So the other thing I wanted to mention is that there aren't very good sensitivities and specificities of these tests, right? And particularly for the LCL, which we'll talk about in a little bit. But that's a little tough because as a clinician, you can't really lay your hat on these tests just because we don't have good data that we might have for like Ottawa ankle rules. We know that like, hey, they're all negative. We have a great sensitivity. If you do a whole bunch of like valgus tests and they're positive, it's like, well, it seems like you have an injury to the MCL. But we don't really know just because we don't always have the best sensitivities and specificities for these tests. So another thing to kind of keep in mind. All right, let's talk a little bit about biomechanics. So obviously we talked about the MCL being a static stabilizer, but what about these dynamic stabilizers across the knee joint we just mentioned? So the pes anserine, which we did a podcast several months ago about the pes anserine. If you want to check that out, maybe I'll put a link in the show notes there. But it attaches right there on the medial side of the knee, right? Almost kind of blends in with the MCL. It doesn't actually attach to it, but it just kind of exists right on top of it. So much so that when you have an injury to the MCL, sometimes it gets caught within the pes anserine tendon. So one of my thoughts is that, yeah, the pes anserine is going to be super important to try to strengthen in those patients after an MCL injury. And also semimembranosus, right? That attaches right through that area as well. And you can see how it's a very important valgus stabilizer. And the quadriceps too. So I think a co-contraction from the quad as well as the hamstrings is probably going to help to stabilize that joint a little bit more so. And for whatever reason, the quad, just like any sort of like injury you have to the knee, the quad just goes like sleep mode. You know, it's kind of like there's some swelling in the joint. If there's like any sort of injury to any structure around the knee, the quad is usually involved. Not always, but it's just one of those muscles that's just super important for most knee injuries. Let's talk a little bit about history and physical examination. So subjectively, what's going on? The patient will often say they had a traumatic injury, they had a contact injury, a blow to the side of the knee, or they had a non-contact injury where they're pivoting on a planted foot. Those can both cause an injury. Generally speaking, there's going to be local swelling, ecchymosis, or bruising, or tenderness in the medial knee. The location of swelling and pain had a 76% accuracy in one of the studies I was looking at in examination. Generally speaking, incomplete injuries are more painful than complete injuries. So if a patient comes in and they've got kind of medial sided knee pain and we kind of do a valgus test and the patient's like, ooh, that hurts a lot. Sometimes I'm like, good, that's a good thing because it generally means that thing is still attached. If you have someone that has a bunch of laxity and zero pain, I'm like, oh boy, this seems like a bit of a grade 3. So kind of clinical pearl that you can use with some of your patients. The other thing I thought was really smart and important from a differential diagnosis perspective is you have joint effusion within 2 hours. That's an indication that there's some intra-articular pathology, right? So you have an ACL injury and there's immediate joint effusion. We know that's a sign ACL is probably injured. If you have medial sided knee pain, medial sided swelling, but no joint effusion, then maybe you don't have a cruciate ligament injury. But obviously, these can be injured together, right? Just a bit of a clinical pearl if you're trying to figure out what's going on within the knee. If I have a patient that comes in, they've got a little bit of valgus, a little bit of laxity, valgus laxity at 25 degrees. They have no laxity at 0 degrees. They have no intra-articular swelling. So sweep test shows nothing. I'm starting to think, all right, maybe grade 1, grade 2 MCL, something along those lines. I could probably treat that conservatively, but I'm starting to see some laxity at 0 and I'm seeing some joint effusion. I'm sending them right back to the doctor, right? Because there's probably something going on within the joint. Could be ACL, could be a meniscus thing, maybe a cartilage issue, who knows? But just something to think about there. Anything to add to that so far, Kevin?
Yeah, I think that's all really good clinical pearl stuff to keep in mind. And then I think just to note on the previous slide, it's always good to understand what the dynamic stabilizers are, because I think that's where we can customize our rehab programs to patients based on their specific pathology and really try to get those other structures as strong as possible. I think it's important to understand that because it's an easy way to explain to patients why some exercises are so important. You kind of let them know that, hey, your static stabilizers are a little compromised right now, so we really have to get these dynamic stabilizers as strong as possible to just support the knee. And then they really buy into that. They kind of understand where you're coming from when you're having them do, in this case, I think some extra adductor work and hamstring quad stuff. They understand why, and I think that helps with buy-in. So it's always good to review that stuff and make sure your exercises are supporting those structures.
Yeah, for sure. I agree with you there, Kevin. All right. What about objective tests? We already chatted a little bit about this. Valgus testing at 30 degrees of flexion is going to indicate an MCL injury. Valgus testing at 0 degrees of flexion indicates more extensive damage and or AMRI, so anterior medial rotary instability, a posterior medial quarter injury, or an ACL injury. So a lot of stuff could be going on there. If that's pretty lax, I'm going to send them back to the doctor. You can also perform a dial test. So this is generally for posterior lateral corner injuries or PCL injuries. Basically, the patient is going to be lying on their belly. They go into tibial external rotation at 30 and 90 degrees of knee flexion. I wrote supine there. That's wrong. It's supposed to be in prone. So if you have greater than 15 degrees of external rotation with anterior tibial translation, so essentially when you do the dial test, you may notice they're having the tibia translate anteriorly, then that's a sign that you may have an injury to the posterior medial corner. You can also perform a Slocum test. So this is a sign that you have the anterior. So this is a sign that you may have anterior medial rotary instability. And you essentially perform an anterior drawer with a foot in 15 degrees of tibial external rotation. And if you have a posterior medial corner injury, you'll notice you'll have more motion of the tibia transferring anteriorly. And it may or may not be the ACL, could be that posterior medial corner. That was a lot, Kevin. I had a hard time saying that. Did that make sense?
It does, yeah. So you're doing your traditional MCL tests, and then maybe also if you are suspecting an injury to that posterior medial corner, you'll see the pain at 0 degrees, right, of knee flexion, and then it may be worth doing a dial test as well to just see if they have any anterior translation of the tibia to help rule that in. Is that kind of right?
Yeah, I think so. I think some of the takeaways are that if you have valgus at 0 degrees, that's bad. Probably need to send back to the doctor. But let's say you're not having a positive test at 0. You may consider doing the Slocum, right? May consider doing that anterior drawer maneuver. And if you are seeing a lot of motion there, then I would just send back to the physician as well, just because those are indicative of something more serious going on and they may need some surgical intervention. All right. What about radiography? So an X-ray can be useful to rule out or rule in a fracture. So this is interesting, but you can have a lateral plateau fracture. So essentially, the lateral plateau fracture is going to masquerade like an MCL sprain. So when you do a valgus test, you're going to see extra motion, but it's not because the MCL is necessarily torn or injured. It could be because there's an injury to the lateral tibial plateau, and essentially you're finding more motion because you kind of cracked the outside of the joint, right? So there's more motion coming from there. You can also do a valgus stress X-ray. So essentially, you can see the person's hand in the image if you're watching on YouTube. You basically perform a valgus stress test and to take an X-ray at the same time. And you can see essentially you can quantify the amount of motion. You can measure the amount of motion, so you can grade that injury, right? And then using MRI is going to be useful for multi-ligament injuries. So essentially, if you've got an injury to the ACL as well, you're going to pick that up with the MRI. It's going to be more indicated in grade 3 injuries because some of the grade 3 injuries may need surgery, and we'll just talk about which ones those are in a minute. Any thoughts to add there before we move on, Kevin?
Yeah, I think that makes sense. I think it's just obviously important to keep in mind, I think especially for maybe newer clinicians, is that if someone comes in and they say, hey, I got some imaging, my knee looks good, you just got to make sure you know what type of imaging they had. Because if they had an X-ray and you're suspecting a ligamentous injury, you got to refer them for perhaps more imaging like an MRI. So yeah, I think that's good. And it is interesting though that the X-ray can pick up on some of that laxity. So yeah, good stuff.
Yeah. All the more reason I think sometimes we take the responsibility of understanding some of this stuff and we just throw it at the doctor, right? And I think that that's important because the doctors are supposed to be the experts in some of the imaging and diagnosis stuff. But sometimes you'll have a patient that maybe goes to a primary care and the primary care may not fully understand the nuances of this, right? And then you have to say, well, wait a second. You had an X-ray? Oh, you didn't get an MRI. Why didn't they have an MRI? You may end up sending back to the doctor just because you're considering they have something additional going on because maybe they had the wrong imaging or whatever it is. So I do think it's important that you kind of understand, at least to a small degree, what we're looking for, X-ray versus MRI, what the patient actually had, because you may have to send them back to a different doctor, and you wouldn't know that if you didn't understand these things.
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So we're going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the fitness pain-free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now.
So let's chit chat a little bit about differential diagnosis. So what else might be going on within the knee when you have an MCL injury? So we know there's concomitant pathology. So if you do have an MCL injury, you could also have an ACL or a PCL injury. So you probably should consider performing a Lockman, looking at posterior sag, posterior draw test, looking for joint effusion. One of the important differentiators between MCL and, let's say, an ACL is that you're going to probably see more joint effusion with an ACL. I've certainly seen folks with zero swelling after ACL. We talked about that in prior podcasts, but more likely you're expecting to see a joint effusion. So using a sweep test. You could also be looking at a meniscus injury. So if you have tenderness to palpation of the medial side of the joint, we know that could be MCL, but it could also be meniscus pathology. We would expect a little bit more joint effusion in these patients. You may also see more pain at end range, right? And the last one that was interesting, and it's really not on my radar, but now it is a little bit more so, is a lateral tibial plateau fracture. I'd be kind of curious if those Canadian Ottawa knee rules would apply here, right? So essentially, if we do some of the palpation, if they can't weight bear type deal, maybe we need to send back to the doctor because it's not an MCL, it's more of like a fracture, right? So anything to add there before we move on, Kevin?
Yeah, I think like you've been pointing out, I think a lot of times this injury to the MCL happens in conjunction with other injuries, right? It's probably very common to also have meniscus pathology, to also have ACL pathology. So it's important to, when you're doing your clinical test, just go through that and kind of make sure that this is on the patient's radar if you're suspecting some other things. And yeah, the lateral tibial plateau fracture, that wouldn't have been on my radar either. So that's also important, I think, to keep in mind. And that's just from the valgus stress, right? I guess you get a very hard impaction of the bones. You might fracture your tibial plateau. And yeah, maybe that person needs to be referred for imaging a little bit sooner, perhaps, or maybe there the X-ray is warranted to see if there is a fracture. So I think that's important to keep in mind.
All right. Conservative versus surgical management. So generally, these are treated conservatively, right? For the most part. We just talked about a good blood supply, and especially for grade 1 and 2, we're going to treat these conservatively, but also for a lot of the grade 3s too. They tend to heal well also. MCL is an extra articular ligament, like we said, has good blood supply, and we also have studies to show that it historically heals really well. And here's the thing. Sometimes when it tears, it's not in a good position. So if I tear my MCL, and let's say the distal fibers tear off, and then they're not laying back down where they're supposed to, it's not going to heal, right? They're sticking straight out to the side. They're just not attached to the area they're supposed to attach to anymore. They're just not going to heal well. So if you are thinking that an individual has a grade 3 injury, we probably just need to send to the surgeon just to make sure that they don't have something else going on that's not going to heal well. The doctor may just refer you right back and say, nah, go ahead and rehab it. But I think for those grade 3s, particularly if you're testing an extension and they've got extra motion, we need to send back to the doc to see what the heck's going on. So from a conservative management standpoint, what are some good general rehab guidelines? Well, for one, this was a pathology that was a little bit sad to me just because we don't have really good guidelines on how we should be treating this. And essentially the research I found, and these were pretty up-to-date papers. They were basically, I think this, my citation here is 2022 or 2024. There's very low quality of evidence to inform our treatment. And of these studies where they do have treatment, they don't really describe the treatment well, which kind of stinks. It's not like they have a protocol that's associated with the rehab. They basically just have a very general outline of what's going on. And also sometimes the individual athletes are treated very differently, right? So you essentially have an injury, you have a study looking at whether or not these folks are returning back to sport and at what rates. and then they don't really include the rehab guidelines or changes from athlete to athlete, which honestly, it should probably change from athlete to athlete. So that makes sense, but doesn't really help us much from a rehab standpoint. Generally speaking, these folks should have immediate weight-bearing is tolerating status. And generally speaking, for grade 2 and grade 3 injuries, they're put in a hinge brace for 3 to 6 weeks. Although this is unclear if it's needed, you're going to find research that shows that these folks get better with or without that brace. So who knows? Maybe you don't need it. Maybe you do need it. Early range of motion is going to be initiated, and we advance rehab based on tolerance, right? So if it's a minor injury and they're tolerating a lot of activity, we keep on pushing. If it takes a little longer, we delay that. So the rehab is going to be based on tolerance. We're going to use progressive strength and range of motion like we would with any other injury. And we're going to progress from, let's say, linear running to multi-directional running and eventually become more sport specific. One of the things I think is really important, it's not one of the things I've taken from these studies, is that think about your dynamic stabilizers. Think about the semimembranosus, the pes anserine, quads, and the calf. Think about all the muscles that cross over that joint. And essentially, you're probably going to treat an MCL injury like you would any other injury of the lower extremity, with more thought to the dynamic stabilizers on the medial side of the joint. And also think about what the MCL does. It's going to control movement in the frontal plane. So from a rehab perspective, we probably start with more sagittal motion, and eventually over the course of time, we work more in the frontal plane and the transverse plane, so on and so forth. Anything to add from a rehab standpoint before moving on, Kevin?
Yeah, I guess I just had a question for the hinged brace. Did you see it all? Would that be something that they're locked in extension for a period of time, or is it more just one of the ones that has a little stability on the medial and lateral side? And like you said, it might not even be needed depending on the person, but
I don't
just
think they
curious.
would lock it, right?
Yeah.
Yeah, it's a good question. First and foremost, I'm not sure, right? I have to
Yeah.
go back and look at that. But from what I remember, I don't think they did. I think they just have them in hinge braced, just to control some of the frontal plane motion is my thought, right?
Yeah.
But yeah, I'm not entirely sure there.
Yeah. And it's probably not something you need to refer for a brace, like you said. Maybe you just have them be a little more cautious in the early phases with their day-to-day activities and make sure that they're not getting worsening instability and pain and swelling, and you're progressing appropriately. You probably don't need a brace, I guess.
Yeah, and like I said, the evidence is mixed. So in a lot of studies, they didn't use a brace whatsoever. So personal bias, I'd probably try not to lock into extension or anything along those lines. If you think about the MCL, it's going to be when you go into deeper degrees of knee flexion, it's going to be a little bit more taut. So essentially, if you lock into extension, maybe you are trying to avoid some strain there. But my other thought is that if it's going to heal by itself and we don't need to lock into extension, I'd rather not. I'd rather try to get people moving as much as we can. Yeah, and if we go without it completely, it seems like that's also okay. So I would assume that it doesn't matter too much at the end of the day. All right. So some return to sport timelines. I taken from this study, the average return to sport was somewhere between 3 and 12 weeks. If you had a grade 1 injury, average days missed were only 10 days. If you had a grade 2 injury, average days missed was around 35. So generally speaking, if you have a lower grade, it's going to return to sport sooner. So if you're testing your athlete and they have, let's say, minimal to no valgus at 25 degrees, you can say, hey, we have some research to show somewhere between 10 and 35 days is how long it takes to return back to sport. My first thought is like, that's actually a little bit fast. And I'm curious what the re-injury rates are for those folks, right? In terms of success rates, and success is defined as patients reporting excellent results on patient-reported outcome measures, somewhere between 70 and 98%. So it's pretty cool. I always tell folks if they injure their MCL, it's the best ligament to injure in your knee, right? Folks tend to heal pretty well and get back to sport pretty quickly. And if you look at, surgical management versus conservative management, so this is for your grade 3s, there are comparable results between groups. The non-surgical group tends to have a faster recovery. So it makes sense. We're almost always trying to rehab these conservatively if possible. And we'll talk in a minute about the types of lesions that you may have to consider surgery with. So, all right. Who does end up needing surgery? Who are the surgical candidates? So essentially, these folks have to be grade 3, and they tend to have medial joint opening in full extension with valgus applied. Folks with an avulsion fracture, particularly a tibial avulsion fracture with the MCL folded into the medial joint, these folks are probably going to need surgery. Reason being is that these folks tend not to heal well. We just talked about this previously. If the MCL is not laying down where it's supposed to lay down, it's not able to heal, right? If it's not attached to that bone anymore, it's pulled away from that bone, it's not going to heal well. You can also have what's called a Stenner lesion. And this is with the MCL lying superficial to the pes anserine tendons. It's a distal tear. So essentially the ligament has been displaced and it can't heal down back on the bone. So if the patient gets some imaging and they have a Stenner lesion, the doctor is going to consider repairing that just because it's probably not going to heal on its own. It's not attached anymore, right? If the patient has a positive dial test indicating anterior medial rotary instability, they're probably going to need surgery. And also if they failed conservative management. So this may have been what your patient had. If you have a patient after 6 weeks, things are not getting better whatsoever, send back to the doctor. You may need to end up having surgery for that. And the other obvious one is if a patient has multi-ligament damage. So essentially if they have an MCL injury as well as an ACL or a PCL or something else going on, we probably need to have surgery for those patients. Any thoughts there, Kevin?
Yeah, I think the conservative slide is pretty encouraging, right? I mean, these folks, like you said, maybe a little too quick, who knows, but their return to sport timelines aren't too bad, and the patient satisfaction is pretty high. So I think, like you said, if you're going to injure a ligament, perhaps the MCL is the best one. And I think it's important to know that, and you can encourage your patient because they might just think all ligaments in the knee are like the ACL, and they're freaking out. But generally it's good to reassure that these do fairly well, and we just kind of progress based on symptoms. And I don't think you're a candidate for surgery with this type of injury. And if they are, then that's okay too. But I think it's good that it's always encouraging that some of our non-op rehab can be pretty helpful for people, and they can get back to higher level activity. So that's pretty good.
Yeah, it's always interesting to me how fast folks will return back to sport after some ligamentous injuries. Think about an ankle sprain, lateral ankle sprain, how fast folks get back. I was surprised with how fast folks got back after the MCL injury as well, right? Around 10 days for something that's, relatively minor, and then about a month seemed like for folks to have a grade 2, so pretty wild, but interesting. Good to be able to tell your patients, give an idea of how long it may take as well. Okay, so we just talked about concomitant injury to the ACL being common in our patients with an MCL. What do we do if both of those are torn together, right? So if there's a grade 1 or grade 2 MCL injury with a complete ACL tear, essentially you can allow the MCL to heal and then perform ACL reconstruction. However, and this is what I tend to see quite a bit, it's common practice to just reconstruct the ACL and manage the MCL conservatively. So essentially a patient has an ACL injury and a concomitant MCL. The doctor doesn't even think about the MCL. They plan based on that based on the ACL, right? And it seems like that's probably fine. If someone has a grade 3 MCL, right? So this is one of those situations where you're potentially considering surgery for that MCL. If medial laxity persists, you can do an MCL reconstruction or an MCL repair, and we'll talk about the difference between the two. They both have similar outcomes. You could also consider having a delayed ACL reconstruction with or without MCL surgery. They tend to have the same outcome. So after you have MCL grade 3 and ACL, you can essentially wait and see if the MCL ends up healing well. If it doesn't, then when you go in for surgery, you can just do both, right? If the MCL kind of heals up and you're not having any sort of instability, when you go in for surgery, then you can just leave that MCL and reconstruct the ACL. Does that make sense? Did I say that appropriately, Kevin?
Yeah, that makes sense. Yeah. I think the MCL ability to heal, it leads to a perfect environment. If they go ahead and reconstruct your ACL, you're forced into a period of downtime and just letting the knee kind of do its thing. And then you start to progressively increase range of motion, and then increase load in a normal post-op ACL situation anyway. So I think it would make sense in those situations that the MCL will do fairly well, and they don't need to touch it because you're forced to kind of go through the rehab process anyway. So I think it works out nicely that way.
Hey friend, if you're liking this content, I have something I think that you're really going to love. And that would be a master course on rotator cuff related pain and rotator cuff tears. Having the patient come through the door and you don't know how to treat their pathology, that stinks. You feel like a fraud, you're just making stuff up. It's not good stuff. It's also pretty dang tough, staying on top of all the literature that's coming out all the time. Well, guess what? I have done this for you by making a master course on rotator cuff related pain. Well, what kind of stuff do you go over in this course? I've got an evidence-based guide. We go over diagnosis and special tests, my favorite beginner, intermediate, and advanced exercises, how to modify your patient's training in the gym so they can keep on working towards their goals and not hurt themselves more, my favorite evidence-based manual therapy techniques for these folks, case studies on how to treat non-op and post-op patients, as well as the exact rotator cuff related pain protocol that I give to my patients when they come to see me with this common issue. Now that sounds pretty good, Dan, but how much does this cost? How does $1 sound? Whoa, $1? That sounds crazy. Why is it so cheap? It's mostly because I don't know how to run a business, but I do know about the rotator cuff, and I'll teach you all about that. This all comes with a subscription to Fitness Pain Free Insiders. It's $1 for 1 week trial and $25 per month afterwards. However, you can cancel at any time. If you don't like it within the first 7 days, just tell me. I will cancel and refund for you. Plus, I have a lot of other really good courses in there as well. We have master courses for cervical radiculopathy, lumbar radicular pain, lateral ankle sprains, and what I'm working on next is, you guessed it, your favorite, shoulder instability. So click on that link in the description. It's $1. Go ahead and get started, and I'll see you on the inside.
All right, let's talk a little bit about surgical technique. We just said we can repair this. We can also reconstruct this. What the heck do we do? At the end of the day, this is usually not our decision. It's going to be the surgeon, but at least you can understand why the surgeon might be making these decisions. Repair is usually advised in acute cases. And one of the thoughts here, and my thought is that, let's say you have a pec tendon that tears, and if you wait long enough, that pec tendon, you can't reattach it, right? It gets smaller, gets harder, kind of pulls away. So I think the same thing is kind of happening after you have an MCL tear that's going on for long enough. You might not be able to pull it back. The tissue is no longer viable, right? If you have an avulsion fracture, this is typically corrected with a screw fixation or anchor sutures. And the anatomic reconstruction is going to be advised in chronic MCL tears. So like I said, if you have something that's not fresh, let's say the MCL is no longer viable, you may have to reconstruct it. It's also advised in folks who have a failed repair. So I'm curious if your patient who had that failed repair is going to get a reconstruction at this point. If there's poor ligament quality, so essentially if the doctor goes in, even if it's acute, they're like, hey, I don't think we can reattach this thing. I don't think we can repair it, right? They may have to do a reconstruction. And there are also some various grafts that can be used. You can also have an allograft and autograft. So you can have a graft either from yourself or from a cadaver. For cadavers, you'll see tibialis anterior or Achilles tendon allografts. Always interesting to me, right? Those seem to be the common ones for the MCL. I guess surgeons have a lot of options. And then for the autografts, you'll typically see IT band or hamstring tendons, right? So again, doctors have a lot of different choices. And it seems like the repair does just as well as a reconstruction. I imagine the graft type doesn't matter too much either, but I didn't pick up on any of that research in my my lit review. Any thoughts there before we move on, Kevin?
You may cover this, but do you know how long the rehab is with one versus the other? Is it slightly different at all between the repair and the reconstruction?
That is a question. I didn't come across that. And in the protocols that I looked at, it didn't mention that there was a difference. So I'm assuming they're similar, although I really am not sure.
Yeah.
I would also assume, based on what I was looking at, that we do not have the research to show one gets back, sooner than the other.
Yeah.
Although the research we do have kind of said it's a similar outcome. So I would kind of assume they're the same, but I don't know.
Yeah. And I would just say clinically, I think the ones I've seen like after a first time injury where they do something to it. I mean, most of the ones I've seen are with ACLs and they're not surgically managed, but the ones I've seen that are repairs versus the reconstruction. But yeah, we'll see what this patient I have with the MCL issue is going to get, because this would be following a failed repair. So I'm curious if they're going to reconstruct or not. So that'd be fun to work with if so.
Time will tell.
I hope it's an Achilles tendon.
Oh, let's hope. Cool. All right. So what are some general rehab guidelines? So essentially, you're asking if there's a difference between grafts. There is a study here. So it's called Postoperative Rehab of Grade 3 Medial Collateral Ligament Injuries, Evidence-Based Rehab and Return to Play. I'm going to leave a link in the show notes, but essentially it outlines rehab post-surgical very much in depth. And the thing is, we have beaten this dead horse in terms of ACL rehab, and the rehab is very similar, with a few specific differences, which we can talk about a little bit here, but we're not going to go in depth on rehab of the MCL, repair reconstruction. But if you want to check it out, just check into the references here and read through that. Essentially, there's going to be a period of non-weight bearing, which is going to be around 6 weeks. Although this is based on mixed evidence, you might not have to be non-weight bearing for that long or at all. So check with your surgeon for sure. Generally speaking, we're delaying knee flexion. You're doing immediate passive range of motion, but we're limiting knee flexion to around 90 degrees for around 2 weeks. And the goal is to have around 30 degrees of knee flexion by about 6 weeks. And then from there, just progressing to full range of motion. Generally speaking, we're using a hinged brace where we're locked in extension initially when weight bearing is tolerated. And then we just have progressive flexion over the course of time. And then we utilize a phased rehabilitation approach. I think one of my major thoughts here is that we're thinking a lot about the dynamic stabilizers. So if you think about, let's say, an ACL reconstruction, we think a lot about the quad as well as the hamstring, because both of those are going to influence tibial translation, right? I think we think about the dynamic stabilizers in MCL repair reconstruction. So pes anserine, we're thinking about semimembranosus. We're thinking about maybe that medial sided gastroc, getting those as strong as possible, as well as the quad. So rehab is very similar to the ACL, I will say, with a few nuances. Anything to add to that, Kevin?
Yeah, I think as a provider, once you get pretty comfortable with post-op knees in general, but specifically ACLs, I guess, because they're so common, it just translates really well to rehabbing these other types of surgeries. Like you said, the phases are pretty similar. And then you just give some special consideration to the dynamic stabilizers that might be impacted with one type of surgery over the other. But that general trend, I guess, the more you see it, and the more you listen to this podcast and learn the phases of rehab, it just gets a lot easier to start to rehab as a young practitioner. So I think it's pretty good stuff.
Yeah, for sure. All righty. What about return to sport rates? So essentially, if I have a grade 3 MCL and I've got a posterior oblique injury, am I able to get back to sport? Well, the one thing I will say is that generally these injuries are creating a lot of damage, and it's not like you have these isolation MCL only frequently. Oftentimes, you end up having a lot of stuff going on. And basically, this paper was looking at grade 3 MCLs and POLs, but also looking at folks had multi-ligamentous knee injuries, right? So take that with a grain of salt. An injury in isolation is going to be very different than a multi-ligament knee injury. Once the ACL gets involved, we know you've got that 9-month time period that you're waiting, right? So generally speaking, these folks had an 88 to 91% success rate of returning back to sport at a recreational level. And this occurred somewhere between the 6 and 12-month range. Keep in mind, if you've got a multi-ligament knee injury, it's probably going to take longer. Study by Lind et al. Showed a 12% return to sport rate, which is abysmal. And this is for higher level folks, an 88% return to sport rate for recreational level athletes. I think the thing to think about is that we know return to sport rate for ACL reconstruction is not phenomenal. If you throw in a couple extra torn ligaments, it's not going to help that return to sport rate. I think multi-ligament knee injuries are a completely different beast. You're just making that rehab much more complicated. It's much more challenging. I think because of that, your return to sport rate goes down quite a bit. Lee and Kim et al. Reported at the return to sport rate at the previous level. And what they found is that there's a 64% return to sport at that prior level of function. So I think that is really important, just because not only are athletes trying to get back to sport, they want to get back to sport at the same level. So let's say that the majority of folks do get back to sport, but they can't play at the same level. If an athlete is considering the surgery based on that, then it's good they just know these stats, right? Anything to add there, Kevin?
Yeah, I think that's so important for all the different types of surgeries that you see fairly regularly as a clinician, is just be able to talk to your patient about that, because that's what they really want to know, right? If you are undergoing a surgery, you're not necessarily thinking about, how long till I'm back. You might be, how long till I'm back walking, how long till I'm out of pain. if you're going to undergo the surgery and you're a college athlete, you want to make sure that you can return to sport. And it's good to know what the rates are there. So when we have that information, I think we can more easily have that conversation with our patients, and they have a better understanding for their decision making. So I think that's really good stuff there. And like you said, maybe some of the ones with the worst return to sport rates, you just wonder if someone's had a multi-ligament knee injury and they had their ACL and MCL reconstructed, what are they going to be getting back to sport? You know, do they feel like they've gone through too much and they just don't want to risk this again, perhaps, and that's why return to sport rates are a little lower? Or is it someone who's failed an MCL repair and now they're doing this again? So maybe where it's these reconstructions they're looking at, because they're usually associated with a major injury, and perhaps a second time, we see return to sport rates a little bit lower. But I think there is some hope with those numbers that your patient could get back to higher level sport, and it's important to kind of talk to them about that.
Yeah, those numbers are a little sad. We know that ACL reconstruction, our number is not as good as we'd like them to be. And I think when you just throw in a couple extra ligaments there, it's even worse, unfortunately. So hopefully we get better at these over the course of time, right? But for now, it seems a little bit bleak. But yeah, good to know. I would say that if you have a grade 1, 2, even 3, and it's conservatively managed, seems like return to sport rates are great. Once we throw in some additional ligaments, it becomes a lot, worse, unfortunately. But so you got some good background on MCL rehabilitation. Here's the thing. Sometimes you hurt your MCL with your ACL, and you need to know how to treat those. And I have a really nice video for you. We're going to leave that baby in the corner. It's right by Kevin's head. We're going to go over everything you need to know about ACL injuries. Go ahead and click on that, and I'll see you there. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain-Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I added to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.